You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Curran Mohan.
Hello and welcome to another episode of All the Pieces. Spinal issues are very common, affecting people of all ages, whether due to trauma, tumors, infections, and much more. But thanks to advancements in technology, surgeries are becoming smaller and safer. Image-guided techniques are revolutionizing the field, leading to less blood loss, fewer complications, and quicker recovery times. Today, we're diving into how these innovations are changing the future of spine surgery. With me, I have Dr. Rosenberg. Welcome, sir.
Thank you.
So, Dr. Rosenberg, before we get started into our discussion, tell us a little bit about yourself.
I am a neurosurgeon. I've been a neurosurgeon for over 30 years, and that entire time I've specialized in complex spine surgery. In the last 15 years or so, I added the neurosurgical treatment of chronic and cancer-related pain to that expertise. Excellent. I've been all over the country. I did all my training in Boston, and then I was on faculty at UC San Francisco, heading up spine, until I decided to go into private practice, which brought me to Kansas City.
Excellent. And you're new to Mosaic. And what have your impressions been so far?
Oh, I've been very impressed.
Excellent.
I didn't know what to expect. I'd been in Kansas City for over 20 years, and I'd obviously heard of Mosaic. And when I came up here, I had no idea, and I was frankly shocked. It was big and beautiful and efficient and friendly, and I was just overwhelmed.
Well, caregivers will be very thankful to hear that. Talk to me about minimally invasive neurosurgeries and the types of patients that you work with.
Well, so for me, it focuses on the spine, and we have had over the last maybe 20 years a revolution in image guidance. And so we are able to bring advanced imagery into the operating room, which allows us to reduce incisions, reduce exposures, reduce blood loss, reduce operating time, and improve accuracy, all of which obviously improves outcomes. So that has completely changed the field of spine surgery.
And when do you consider the surgery as the option? Are there any non-surgical options for any kind of, say, spinal pain from cancer?
Oh, of course, for cancer and everything else.
Right.
It may sound trite these days, but everything has to be patient-centered.
Right.
So it's not about the surgery, it's about the patient. And now sometimes surgery is a good answer. Sometimes it's not. Sometimes there are multiple answers, and that has to be a conversation with the patient as to his or her goals and expectations and things like that. So it's rarely, in my area, you need spine surgery. It's more of a discussion and a journey.
Right, and that's a very patient-centered attitude, especially in this field where at least the impression is, let's take them to the OR, right? And that's a very nuanced conversation because sometimes surgery is not the best option.
Absolutely, often. I mean, I would say probably greater than 50% of the time in my clinic, I'm telling patients they should not have surgery.
And what would be sort of the exclusions that you might consider?
Well, I wouldn't. Sometimes there are exclusions if they're too sick, for instance, but it's more of, well, let's try some other things before we, everything in life is risk versus benefit, whether you're investing in the stock market or having surgery.
Sure, not too bad, especially.
Now especially. So what's the risk? What's the potential benefit? And when those things don't make sense, you need to go on to the next option. Yeah. So, and that evolves as you try different things. And that's why it's more of when I added pain expertise, it was, I loved it. It was very exciting because that gave me a much bigger toolbox. Right. And I could have these conversations with patients like, we have 3 different options. Here are the pluses, here are the minuses. How do you, what makes the most sense to you in how do we proceed, knowing that there could be plan B or plan C or plan D, depending on how things evolve.
Right. So tell me a little bit more about the pain part of things. are you just giving them patches and pills, or is it more targeted?
So I don't usually do medical management.
Gotcha.
Sometimes, but not usually. So I'm not a pain physician. I rely on those pain doctors and collaborate with them. I bring neurosurgical treatment of pain to the table, and that's a field. Right. It sort of died out for a few decades, and then it came back to life recently. And so I've been very involved on national and international levels to do that. But that involves things like spinal cord stimulation, targeted drug delivery, certain procedures that we do, many of which are outpatient in neurosurgery for cancer-related pain, things like cordotomy, myelotomy. So there's a lot of different options, and it really requires a team approach. So in collaboration with palliative care, with pain, with physiatry, we can come up with a team, and of course the oncologist in the case of cancer pain. We need to have a team approach.
Excellent. You mentioned all these tools in your arsenal, if you will. What are some of the newer technologies that you're seeing will be offered at Mosaic?
Well, the image guidance, I've said it before, and that has been offered here that's not something I'm bringing. That has been here. But I think we can use it more and more, and again, to get more efficient, smaller surgeries with better outcomes.
So what makes a spinal surgery simple versus complex? Because I know you mentioned complex spinal surgery throughout this discussion so far.
Yes, I think that's... sometimes it's a little bit like
complex,
beauty is in the eye of the beholder. So sure. Complex for some people might be simple for others.
Sure.
Typically what we loosely refer to is there are some fairly straightforward procedures, like people might be familiar with discectomy or laminectomy, where we take a little piece of bone off or take a little piece of disc off, and oftentimes those are done as outpatients or maybe a short overnight stay. And no surgery that's being done on you is simple.
Right.
Every surgery that done on me is very, very serious.
Mm-hmm. Right.
But from a spine standpoint, it's fairly straightforward. Right. And then we get into more complex things, putting in instrumentation, fusions, correcting deformities like scoliosis or things like that, resecting tumors, resecting infections. That would be considered complex spine surgery.
Excellent. So you mentioned discectomies, laminectomies. What else you think is coming on the horizon as our population is getting older and, or let's just say advanced in age?
Well, taking the totality of my area, I would say, as I alluded to, the options. So oftentimes, I've seen this many times, where there might be an elderly person who comes in and they've got a pretty bad looking spine, and it might have a curve to it, and there might be one nerve root that's just being compressed a little bit. All of the other stuff doesn't need treatment. So the question is, as a spine surgeon, you go in, it's a little bit like playing with a house of cards, and you start pulling one card out, and you open the whole thing, doesn't fall over. So that's where oftentimes people with relatively straightforward problems get recommendations for extensive fusions, for instance. And that's not wrong, but if you could get away with solving the problem, you don't need all the screws and rods.
Right.
And that's where things like spinal cord stimulation might come in.
Okay.
So
what is that?
Well, in spinal cord stimulation, there's a few very nice things about it. It's all outpatient procedure, and it has what's called a trial. So the trial, often done by the pain doctors, is through needles, and a couple of leads are wiggled up next to the spinal cord, and then the patient gets to try it for a week and go home, do things, see how it works.
A test drive.
Test drive, right. And if that trial run says, wow, that's really helpful, then oftentimes they send them to me, and I put it in what's called permanently, although we can take it out, and that involves a small battery, like a pacemaker battery,
right.
But it's put closer to where the incision is in the upper buttocks. And it's all inside, and they use it. It can be very effective. So it does not help with weakness. It does not help with sensory deficits, like numbness. But it can help greatly with pain. So in somebody whose only symptom is pain, and there's nothing that mandates correction, a gross instability of the spine or something like that. Sometimes, and that's actually what I consider the fun part of my job, is we can have a long discussion about, well, we could do A or we could do B.
Right.
And the fact is we don't burn any bridges. We can do one, and if that's successful, great. And if not, we can do the other. So I like giving people options.
I like that too. It's a very patient-centered discussion, and it sounds like the advancements made since when you were in training to now, it seems like a lot of your colleagues have a lot of tools to offer to the patients.
Yeah.
Well, there you have it, folks. We're extremely appreciative of Dr. Rosenberg and honored to have him be part of the Mosaic team. And until next time, take care, brush your hair.